tends to pull your patella down a little bit, so that's that patella baja, and so it's creating more stress as your patella is riding over, so you tend to get arthritis faster. And then again, extensor mechanism, so getting the patient back to, extending their leg is a big one. So it is a very good graft other than that. The newest one is the there we go. Newest graft is the quads tendon. So again, we're going in just up above the patella now. What's nice with this is the surgeon can kind of create the graft that he wants. So he creates the length, he creates the width, he creates the depth. So it's very consistent. You do get direct bone-to-bone integration because it is kind of just a more robust graft. Stability is good, lower morbidity. Again, you're going to have a bigger incision, more extensor mechanisms, and there's a learning curve. I've seen it where surgeons don't make the graft deep enough, so all of a sudden they kind of have this small graft that doesn't really work very well. So that's that. Again, when we get to graft selection, re-tear rates, clinical outcomes, this is a bit of a review. Donor site morbidity, post-op patient experience. So I'm finding that with quads tendons, as surgeons start to use it, they see how the patients do, all of a sudden they tend to use them more. So that's that. And then surgeon experience and training. Once we have our graft, now we have to figure out how to drill. Okay, there's again several options here. We'll go through. Dr. Henson, Dr. Cheney basically just do one type, but there is a whole bunch. I was in a case last week with a surgeon in Lethbridge. Dr. Kwan, he's been doing them for 30 years. Actually, we did a revision of one of his here the other day. I'm not sure if any of you were in it, but there was only a tibial tunnel. He took the femoral, took the graft, hooked it, put it through the knee, hooked it over the condyle, and used staples. So it's an old style. Still works well, still does it. So the aim here is to reconstruct the ACL using our native anatomic footprint. So they will spend a lot of time figuring out where that graft is going to come out of the tibia, where it's going to enter the femur, and there's some reasons for that because it can really help how that feels to people. So our entire drilling options. So AM portal technique is, they sort of ignore most of the tibial stuff here right now. This is talking about the femur. This is what you guys would be familiar with, where they're looking at the camera, they're going in and finding that little spot. He's using that little guide to make sure he's far enough off and drilling through there. What's nice with it is you're drilling the tunnel independent of the tibial tunnel. Back in the day, and we'll get to that with this transtibial technique, don't need any special guides or instrumentation. Sometimes they like to have something just to quantify it a bit. You get to see the tunnel, and it's very, very reproducible. Disadvantages, a steep learning curve. I think everybody kind of does this now, so it's not really that steep. The possibility of a short tunnel. So if we look over there at my expert art, you can kind of see sort of a typical example of that femoral tunnel. The problem with the AM portal technique is if we're going here, so we're coming in through, we can really vary how this angle is. So all of a sudden, if I go too far lateral, I end up with a very, very short tunnel. Why does that matter? With a short tunnel, we don't have a lot of room for the graft to incorporate, and it can, fail. The other thing that can happen is now we're trying to get this graft going up and around a corner. So again, you've probably seen surgeons struggle a little bit trying to get that graft all the way through. Sometimes that can be an issue because we're going up and then we're trying to make a hard right or hard left in this case. The only other thing that you'll see with the AM portal technique is as they're doing this, in order to get around everything, they really have to hyperflex the knee. So this one doesn't flex very well because of my ACL. So they really have to push it up there in order to get that visualization, which, you know, in a larger BMI patient can kind of be hard to do, things like that. The outside in technique, it's a newer technique. I think this is more just to sell things in the US, where surgeons we're basically using a drill that goes in through the femur, and then you hit reverse on it and there's a little blade that pops out, and you can kind of suck back to get your graft tunnel, and then you kind of push it through. So drills are expensive. I don't want any of that at all. So
You did it.
perfect. So drills are expensive. I've done a couple of these in the past. They're very fiddly, but it tends to be a very nice marketing ploy for surgeons in the States. So
Those drills are single use, I guess.
of course, yeah.
Break sometimes inside.
Yeah.
Done them in the States and they break.
100%. That little extra
The
blade is
flip,
quite
whatever they're
the
called,
flip blade.
Yeah.
Oh,
Yeah.
God.
I've
Yeah.
seen them break inside the bone.
So, you know, the one advantage is you do get really nice cortex on there, and you can do that on the femoral side and on the tibial side. So I don't see much of that up here at all. The all inside technique, kind of the same thing, just doing it on the femur and the tibia. So again, more chance for the blade to break, etc., etc. Transtibial is a very old school option. What they would do is bend the knee in a correct position, go through our tibia, and then carry on into the femur. So from here and all the way through. I think it's really nice to pass the graft. It's really fallen out of favor, and the big reason for that is, you know, we're talking about this femoral tunnel being too lateral. In this case, the femoral tunnel gets too vertical. So what that does for the biomechanics is it makes the knee feel unstable in rotation. So I have to wear a knee brace when I'm skiing now because it doesn't feel very good. So I don't see a lot of people doing that anymore. That rotational stability, we'll talk a little bit when we get into that LET thing here. So, and then the inside out flexible technique, again, not really applicable unless you're trying to market to get some more business, which none of our surgeons are. Which leads us into our third choice here, which is fixation options. So this is where everybody gets confused. What the heck do these guys want to use for everything? So when we look at this, basically all the fixation options are good, but it really depends on the graft, and then again depends on the tunnel that we've drilled. So it needs to be clinically acceptable, basically. So graft choice, patient factors such as age, primary or revision can make a difference, and surgeon training. So if we look at this, and we can talk about some of our products, you know, Arthrex has a lot of similar ones, obviously not as good. So we look at fixed loop fixation. Okay, you guys that have done a lot of ACLs have seen a lot of this. This is our endo button with the 15, 20, 25 mil closed loop on it. Okay. What's nice with this is there's no creep. This loop can't stretch at all, so that's important in those initial stages of healing. So we can kind of maximize graft in the tunnel. The disadvantages, biggest thing is when we're using our endo button, you know, essentially it's something like this. It's going up through the bone, and then it's flipping, and now it's resting on the cortex, and you can't pull it back. So it's great fixation. Problem is, with this loop, you need enough room for this to come and then flip. As this flips, now there's 6 millimeters of gap in that femoral tunnel. Eventually it gets filled, but it takes longer. And you can have a bit of a wiper effect, you know, as this is dangling from here, it can move a little bit, which can, you know, kind of cut the graft a little bit. And then there's some math, which nobody ever likes to do. So. Our adjustable loop fixation. So that's going to be our ultra button, which Dr. Hansen uses pretty much all the time. What is nice with this is you get that same flip, that same button on our cortex. So you can use that with basically any graft. So he's got one for his quad tendon grafts. He's got one for his hamstring grafts. The nice thing is once we flip this, now we have, it's sort of like that Chinese finger trap where you pull and it sucks that graft up into the tunnel. Okay, so we go back to the endo button and we have that 6 millimeters of unfilled tunnel. We can get rid of that. Okay, so much better healing. Again, we can go to a slightly shorter tunnel because of that. Only problem with this is every once in a while you will see a little bit of creep or a little bit of stretch because it's knotless. So, you know, all of a sudden, sometimes they will creep back a little bit. But it seems to be kind of I would say 90 to 95% of surgeons, this is what they use on the femoral side. Now, depending on the graft, so if we're using a hamstring graft, what are we going to do on the tibia? This is where the screw comes in, and those of you who have done it have all seen them use a screw on the tibial side. So long history of use, press fit, fixation, no calculations, you know, all graft types. You know, and it's really, really nice on a hamstring graft because you generally have some graft hanging out the tibia. And so we can pull that tight, make sure there's no stretch or anything like that. And then we put a little guide wire up there, get the screw, and that pushes that graft out to the walls of the tunnel, so it ensures that it's touching, which is massive for healing. And, you know, just quick and easy and relatively inexpensive. So you can use it on the femoral side. That's really fallen out of favor with like a button type fixation. Disadvantages, back in the day they were using titanium screws, so there's a potential to lacerate the graft, potential for posterior blowout. So that's more if they were using it on the femoral side. You know, that screw all of a sudden, if we don't have a lot of cortex, you know, can kind of blow out the back if the bone quality isn't good. It can be challenging to revise, especially with those titanium screws. Now most of those screws are either a PEEK material, which you can drill through very, very easily if you're doing a total knee after, or it's some sort of absorbable screw, which I think is what you guys have here. So, what else? Suture discs. So we are seeing that quite a bit, especially with our quad tendon grafts. So we've got our endo button or ultra button on the femoral side. We're going through the tunnel, down out the tibia. Quad tendon grafts tend to be a lot shorter, so you don't have a lot of tendon hanging out the bottom. So in this case, we're going to do another button of sorts. In this case, they're going to be bigger because we've got to cover off the diameter of the entire graft with it. So we have like a small, medium, large tibial button. So very, very quick, very, very easy. Again, they can tighten it after, which leads to the disadvantages is all of a sudden it can creep back a little bit, or the suture breaks. We've all seen that once in a while, but the knotted suture over the disc is the weak point of the fixation. But again, nice and fast and easy. And then the hybrid approach, which is really a combination of our fixed or adjustable loop fixation on the femur, and then screw fixation on the tibia. That's again probably 90-95% of what we're seeing. Quick and easy. Making sense so far? So products we have here on the shelf. So our endo button, which is our closed loop, so like 15, 20, 25, 30. Our extendo button and tibial buttons, the ultra button, which is the adjustable button for our cortex, and then our screws. So this is our peak materials.
Can you touch that screen? Is it touch screen?
No.
No.
Oh.
It's
I
just-
was really
Whoa! Get to where you can.
Dory will
Just
be
keep
there.
trying.
Yeah.
Where are these fingerprints here?
There we go. And then our Regenazorb, which is our absorbable screw, which absorbs over the course of 12 to 18 months, kind of thing. This is basically what we went through. So surgeon's going to choose his graft option, choose his drilling technique, his fixation technique for the femur, and fixation technique for the tibia. So that's basically all I had from my presentation point. Wanted to open up for questions, concerns. What are you guys finding challenging with this?
For me, it's just hard to consolidate because we see them so infrequently.
Yeah.
We see it once in a blue moon, and it's just based on chance whether or not we're in that room or not.
Okay.
Yeah.
Okay.
Yeah, he does
Yep.
a lot of them for me.
Thanks.
I know. Yeah. Right. Yeah. We've noticed a massive shift there because he's going to Fernie so much. I've been out there quite a bit. One of the things I'm trying to do is, when I see them come through, I'll try and be here all the time,
Cool.
Which will help. The other thing just going through the list, and I'll kind of go through it with you guys maybe after, is in Medicine Hat, what I did was created some some bins. So hamstring graft ACL bin, and then you can just at least pull all the stuff you need without thinking. Now you're in the room at least, and now everything is in the room. So I think that would be helpful. And then
You have a list of what's in the bin so that we can
Yeah,
restock
I like that.
Of course. Of course.
I'm
I
not
actually,
saying-
I have that on my
it.
computer
I'm
right
not
now.
saying it
From-
will get restocked, but if
No,
the
but
option is there.
at least if you're there and there's
Yes.
3 items,
Yeah.
now you know what else to go pick.
Yeah.
Yeah.
And I think that's, to me,
Totally.
that's where we need to go with this stuff.
Yeah.
Because you guys get pulled in so many different directions, and you're gonna do an ACL middle of March, and you're not gonna do another one till October.
Yeah.
So why would we expect you to know that? So that's a change you'll see over the next little bit, is I'll put that together over the next 2-3 weeks and do that for you. I don't think Dr. Hansen's not really doing much for quad tendons out here, so we can just do one, and it'll just be a case
Yep.
cart thing. So that would be good. Yeah. What else? Anything good?